Hello, welcome back. In our last video lecture, we're going to be talking about high-risk pregnancy, delivery, and complications, and how to code them. And I believe we left off here, so let me advance it. And again, we talked about some of these complications following ectopic and molar pregnancies falling into codes O00 through O02. Again, main terms, pregnancy, ectopic, pregnancy, molar. Now we get into more interesting things in terms of high-risk pregnancy. High-risk pregnancy supervision codes are used only during prenatal care, not at delivery and not postpartum. And if you think about it, of course, it makes sense. For complications during delivery, that is a result of a high risk pregnancy, the pregnancy complication code from chapter 15 is assigned instead of the code from the O09 supervision of high risk pregnancy. And some examples of some of these high risk pregnancy codes. We see insufficient prenatal care, elderly pregnant females, young pregnant females, pregnancy as a result of assisted reproductive technology, and so on. The sixth character in the code will identify the first, second, third, or unspecified trimester of the pregnancy when the supervision occurred. The main term, of course, is pregnancy, supervision of high risk. Threatened abortion involves bleeding but no loss of pregnancy, making the documentation critical. This usually occurring before the 20th completed week with or without uterine colic, expulsion of products of conception, or without dilation of the cervix. And again, when we use the term threatened abortion, we're meaning that the loss of pregnancy is prevented. Main term, of course, would be abortion or threatened. Recurrent pregnancy loss depends on whether the patient is currently pregnant. And this is also documented sometimes as habitual or recurrent abortion. And if the recurrent spontaneous abortion is current in this admission, the code for spontaneous abortion is assigned. As it says in the second bullet point, if the current admission or encounter is for a female is pregnant, the code for the patient with recurrent pregnancy loss is assigned. And if the current admission or encounter does not involve a pregnancy, we would use the code category N96 recurrent pregnancy loss and not something from the chapter 15 obstetrics chapter. Remember, we only apply these codes for the pregnancy. And again, another thing that we see a lot of is the definitions. Preterm, once again, delivery before 37 weeks of gestation. Term, any delivery that falls between 38 and 40 completed weeks. Post-term, delivery between 41 and 42 weeks gestation. And prolonged, anything beyond 42 weeks. Postpartum begins immediately after delivery and occurs for 42 days or 6 weeks. And again, another thing that is confusing to some people is the encounter for an uncomplicated delivery. An uncomplicated full-term delivery means that we have a full term, in other words, 40-week gestation, single live born infant. It's a spontaneous cephalic vaginal delivery, and it's a delivery requiring minimal or no assistance with or without episiotomy without fetal manipulation or any instruments such as forceps. We use a single code from the OB chapter with an outcome of delivery code of Z37. Right? If we have a cesarean delivery, which falls into code category 082, that is not a normal delivery, right? And any cesarean delivery without any documented indication usually should result in a provider query. Outcome delivery codes from code category Z37 should be included on all maternal delivery records and should never go on the newborn record. This is always an additional code. The main term is outcome of delivery. Pregnancy can complicate pre-existing conditions, or these conditions can complicate the pregnancy. Here's an example of what we're talking about with pre-existing hypertension. Pre-existing hypertension falling into code category 010, 010. It's hypertension complicating the pregnancy, childbirth, and postpartum. Main term again, pregnancy complicated by hypertension or pregnancy hypertension. And the fourth character will identify the pre-existing hypertension. We could have essential hypertension, hypertensive heart disease, hypertensive chronic kidney disease, secondary hypertension, or unspecified pre-existing hypertension. There's specific coding instructions under code subcategories 010.1, 010.2, and others that will tell us to use the additional codes to identify the hypertension. Gestational hypertension, preeclampsia, and eclampsia are pregnancy-specific conditions with clear, specific, distinct coding rules. Gestational hypertension is hypertension that did not exist in the woman prior to pregnancy, but rather the pregnancy induced or caused the hypertension, right? And this occurs usually during or after the 20th week of gestation. Preeclampsia is the presence of hypertension and proteinuria with or without coexisting systematic or abnormalities involving the kidneys, liver, or blood, right? So again, have to read very carefully to figure out whether it's hypertension, preeclampsia, or eclampsia. The difference between eclampsia and preeclampsia, eclampsia is a new onset of grand mal seizure activity or an unexplained coma during the pregnancy or postpartum in a woman with preeclampsia. And again, the main term would be pregnancy complicated by eclampsia, or edema, or preeclampsia, or eclampsia with the main terms of preeclampsia or eclampsia. We can have excessive vomiting during a pregnancy. This falls into code category 021, right? Hyperemesis gravidarum, this kind of severe morning sickness. And again, main term would be pregnancy complicated by vomiting or hyperemesis. Late pregnancy falls into code category 048. Pregnant women who are beyond 40 weeks of gestation. This is a prolonged pregnancy, right? And this is considered high risk. The main terms, which is something I would recommend people to go back and review, would be pregnancy, post-term, or post-mature, or prolonged. Preterm labor with or without delivery falls into code category 060, and this is the onset of spontaneous labor before 37 completed weeks of gestation. And the codes exist for both preterm labor with and without delivery. If we have a delivery of a live-born infant as a result of an elective abortion, it's coded as an elective termination of pregnancy, Z33.2, with a code from category Z37 for the outcome of delivery. If the preterm labor and delivery prior to the completion of 20 weeks of pregnancy and the infant is not live born, the spontaneous abortion diagnosis would be the diagnosis provided by the physician. Finally, we get into puerperal sepsis and other postpartum infections falling into 085 and 086. These are conditions that occur during the 6 weeks following delivery. We use an additional code of B95 through B97 to identify the infectious agent responsible for the infection. And the same types of sepsis rules we saw earlier would apply here. If severe sepsis is present, an additional code would be from the R65.20 or R65.21. The main term would be puerperal sepsis or sepsis puerperal. The codes from code category 085 are not assigned for sepsis following an obstetric procedure. Instead, we would look for codes from the T81.40 through T81.44 range. Codes 086 identify the localized infections that occur during the postpartum infection. And again, you may want to read the guideline that falls into guideline 1.C.1.D.5.B, sepsis due to post-procedural infection. And that's all I have for you. Please reach out if you have any questions about this material on coding maternal conditions. That's all I have for you. We'll see you online. Bye now.